we were doing the management. Okay, so so we already know identifying the exhibiting factors, asthma pharmacotherapy of acute acute exacerbation and long-term management, regular assessment and monitoring, and patient education. Okay, so so eliminating the exacerbating factors is very important. So we should ask the patients to keep their rooms clean and dust-free, avoid heavy curtains which attract the dust, clean regularly the beds, carpets, stuffed furnitures, and books, because these are the things which keep the dust a lot of times. Avoiding the pets in the house is very important for them. Avoid smoke, incense, or perfumes, disinfectants, and paints, because the strong smell of these things can again exacerbate an asthma. Pharmacotherapy has two kinds. Okay, so that was we have to first diagnose what is the factor, and then we should give them some advices like this. Okay, so pharmacotherapy is one which we should all know. So the two categories to for our treatment is, first is to relax the smooth muscle and dilate the airway. Okay, so one very important pathophysiology was contraction of the smooth muscles leading to airway obstruction, isn't it? So we have to relax those smooth muscles, and we decrease the inflammation and prevent exacerbation. So along with that, inflammation was going to cause edema and secretions production. Okay, so we will do the relaxation of smooth muscles and decrease the inflammation by reducing the edema. Okay, so we use two drugs to do these things. Okay, so for quick relief medication, so whenever there is an attack, something that acts very fast are beta-2 agonists like salbutamol and terbutaline. These two are very fast acting beta-2 agonists, and both of them do help in the relaxation of the smooth muscles. Okay, smooth muscle relaxation are the main important work of beta-2 agonist. Then is anticholinergics. Anticholinergics basically ipratropium bromide, that will help in reducing the secretions. So the secretions which were mucus secretion was there, that will be decreased by ipratropium. Okay, because it is anticholinergic. So anticholinergics will help in reducing the secretions. Then to reduce the inflammation, we may give them a short course of systemic steroids. So oral prednisolone or methylprednisolone can be given, systemic, oral or IV. We can give some steroids to reduce the quick reduction of their inflammation. Steroids, but for prolonged treatment, we give inhaled steroids. Okay. Okay. Then is long-term control medications, like, so those are known as controllers. Okay, so this one is quick relief medication. When a patient comes to you in wheezing, we give this kind of treatment. But when the patient is already been treated for this acute condition, we give him something that will control his treatment, control his disease. We will do some treatment for his controlling the disease, and thus will reduce the exacerbation. Okay, so basically this controller will avoid the exacerbations of bronchial asthma. So what we do is we give inhaled steroids. So the inhaled steroids are the first line treatment in case of controller therapy. It can be a low, medium, or high dose steroids. Okay, so budesonide is a very commonly used inhaled corticosteroid which we use. Others are beclomethasone, fluticasone, flunisolide, and mometazone. Okay, so first line therapy, inhaled steroid. Then is mast cell stabilizer. Sometimes chromoline and nidocromil were used earlier. These days, these are out of treatment part, but earlier they used to be used chromoline and nidocromil. Okay, then is leukotriene modifiers. So leukotriene modifiers are montelukast, zephyr-leucast, and zilutin. And montelukast is very commonly used these days for controller therapy. Then is long-term inhaled beta agonist. So salbutamol was short-acting beta agonist. Salmeterol and formoterol, these are long-acting beta agonists. Okay, so you give the treatment, it will act for nearly 12 hours. But salbutamol generally acts for 1 to 2 hours or 3 to 4 hours. Okay, so long-acting beta-2 agonist can also be a controller therapy. Then is a sustained release theophylline. So theophylline are also something we can add if the response is not coming. Okay, for step 3, step 4 level, we sometimes add theophylline also. So what is the steps to start medication? So first we have to assess the severity of the asthma. So what treatment you are going to give? So that is depends upon the severity of the asthma, how you are going to start the treatment. Then we have to select the medication. So what medication can be good for the patient, which will produce least side effect and will give the most response. Okay. Then select the appropriate inhalation device. So because most of the time we give the treatment in form of inhalation, we avoid systemic treatment because systemic treatment have a lot of side effects. But if you give something by inhalation, it's going to give a least systemic absorption and least side effects. So we have to, in case of children, we always try to select the device which we are going to give you the inhalation. Okay, then we have to monitor and modify the treatment. We have to monitor the treatment because whether it's improving, it's deteriorating, or static, how the disease is going on, and we have to modify our treatment according to the position of the patient. Okay, so first we uh, we label someone as mild intermittent asthma. Okay, so how do you label him a mild intermittent asthma? Is the day symptom is less than 1 per week, or night symptoms are less than 2 per month. Or we do the lung function. The pulmonary function test shows more than 80% of expected, or variability is less than 20%. Means lung function is normal, but he has day symptoms and night symptoms which are very less. Okay, so in that case of time, we will advise him to get a short course of beta 2 agonist SOS. SOS means if he has symptoms, like if he has cough once a week in the day, you just advise him to give a inhaled salbutamol puff. Okay, you give him an inhaler of salbutamol, and you ask him to take the puff whenever he has a symptom. But his symptom should be less than 1 day symptom in a week, or in a month, only 2 nights he should take this puff. If he's taking more, it means it's not a mild intermittent. Okay, it goes to a higher severity. Okay, so in that case, we don't need any controller medicine because this much of symptoms is not going to harm the patient or harm his daily life. That's why we don't put him any controller medicine. Then is mild persistent. He has similar symptoms more than 1 day a week or less than once per day. He don't have all the 7 days, but he has more than 1 day a week. Okay, so 2 times or 3 times a week. If he has symptoms, day symptoms, and he has to take the puff. Night symptoms, more than 2 nights are affected in a month. But if you see the pulmonary function test, PF is more than or 80% expected, but the variability is a little bit more. So in the last, variability was less than 20%. But in PF, variability means if you make an exercise or if you do give a salbutamol puff and you see the variability, sorry, this is variability from the morning and evening, sorry. Okay, so PF variability means it is variable from morning and evening. You do the PF at the morning and do PF at the evening time, and the variability is more than 20 to 30% variable is you find, then it is mild persistent. Okay, in that case, you can ask the patient to take short beta 2 agonist SS. Whenever he has cough, he can take some salbutamol puff. Along with that, you should start some inhaled steroid on this patient, okay? Or cromolyn or leukotriene inhibitor. So cromolyn these days we don't use. Leukotriene inhibitor is a oral drug. Okay, so we don't get an injection. So we first generally start with low dose inhaled steroids. Okay, then is moderately persistent, means he has daily day symptoms. He has cough every day and he has more than 1 day symptoms, and he has more than 1 week. Okay, And if you see the lung function, but less than 80% of the expected, and the variability in the morning and evening is more than 30%. So you should label it as moderate persistent. That is persistent symptoms and it's moderate. In that case, short course, whenever he has symptoms, he can take a puff of salbutamol. But along with that, we should add some inhaled steroids or inhaled steroids with leukotriene modifier like montelukast, or long-acting beta agonist like a salmeterol or formoterol. Okay, so you can give. So it's your option that you can try a medium dose, like you gave some steroid last time. You have to increase the dose of the steroid. Okay, one is you can increase the dose. Two is you can keep the dose same or add some leukotriene modifier in form of montelukast or salmeterol or formoterol in form of nebulizer only. Sorry, inhaled salmeterol also. Okay, so whenever you have a moderate persistent, you should give a higher dose of steroid inhaled form, or we can add leukotriene modifier or LABA. Okay. Then it's severe persistent, means he's having a lot of symptoms. Day symptoms causing his activity being affected. And very night frequent symptoms, that is nearly every night. Okay, frequent exacerbations, and he's having a lot of exacerbations means, I'll tell you in next slide. Exacerbation will be acute condition. He will land up in the emergency with shortness of breath. Okay, so frequently he's landing into your ER or OPD with exacerbations. So it is having severe persistent asthma. And if you see the lung function test, the lung function test is pulmonary expiratory flow rate is less than 60% of expected, or variability is more than 30%, then you should label it as severe persistent. In this case, short-acting salbutamol nebulization is always there. Anti-inflammatory in form of high dose of steroid. And now your steroid is in the maximum space. And we have to add some montelukast or salmeterol in his inhalation form. Along with that, you can give some theophylline. Okay, so you have options is you give high dose of steroid plus montelukast or salmeterol, or add some theophylline. Okay, or we can add is, because he is having severe persistent illness for short time, for that kind of short time, we can add some oral steroid for the reducing his severe persistent symptoms. Okay, so that his exacerbations is landing up in the ER is decreased. So this all depends upon your treatment modality. Okay, what you want to add. If he can tolerate oral steroids, he has no symptoms of steroid toxicity in your past. Okay, so like no Cushingoid features, no skin thinning. Okay, you have not seen any side effect of steroid in that patient earlier, then you can give oral steroid very good, because it will respond very nicely. But if you think that steroid is already on high dose, you don't want to give a steroid toxicity to the patient, then you can try 2-3 drugs at one time. If it's not responding, then go on to your steroid addition. Okay, so generally, basically, we start slowly. We give inhaled steroid, dose increasing, add on montelukast or inhaled salmeterol, add some theophylline if the patient can respond or can tolerate theophylline side effects. Okay, you can add theophylline, but in children we use theophylline very less. Before theophylline, we try to give oral steroid for a short time, like 7 days, not very long. Okay, then we can reduce the steroids slowly, and the patient's symptoms will go off, and then we will continue the patient on inhaled high steroid and montelukast. Okay, so just labeling doesn't mean that you have to give all the drugs. Okay, so basically we are labeling so that the patient's response can be seen. After a few days, where is he? He is still at severe persistent, or he has come down to moderate persistent, or he's going more into exacerbations. Okay, so we should label and see the patient's movement. Where is he? He's going down or up. Okay, so MDI is meter dose inhaler. Okay, so we use these kind of MDIs very commonly in children. Okay, so what is this? It is a multi-dose device. From this device, you can take a multi-doses it delivers a fixed amount of medication in aerosol form each time it is activated. Okay, so it will deliver a fixed amount of drug which you want to give in the form of aerosol. It contains micronized powder medication with dispersal agent and propellant system. Okay, so what happens? There is a liquid with medicine in it, and when you use this propellant system, what happens? This liquid is converted into aerosol, and the patient can inhale that aerosol. It basically works just like an LPG gas. In LPG gas, you have a liquid thing, and when you open the regulator, the liquid will change into gas. So similar kind of system works in this. Okay, and it requires a good coordination. When you push the puff, the patient should take a deep breath. So this coordination of pushing the puff and deep breath is very important in this case. Okay. Another thing, this is MDI. Okay, this part is known as meter dose inhaler. Another thing we use in children is known as spacer. So I'll show you that first. Okay, so this transparent thing, this is a spacer. Okay, and on that there is MDI is fixed on one place. Okay, so this spacer is required in children under 4 years who cannot use MDI. Oh, sorry. So so the person who do not have a proper coordination, like we push the puff and we cannot take the deep breath. This coordination is poor. In that case, we use this spacer. What happens? We push the puff into the spacer and the patient can slowly take the breath from this box. So if you push the drug into this spacer, the patient will take the breath for 30 seconds to 1 minute. The whole drug will be taken by the patient because there is a fish valve over here. The patient is only going to inhale the air inside from here. His exhaled air will not go inside it. That's why mixing is never occurring because of fish mouth valve in this end. Okay, from here the patient will take the breath. Under 4 years of child sometimes cannot use this spacer also, because in this spacer also they have to do the inhalation from this part. Okay, they have to take some deep breath from the mouth. But the child who are below 4 years, they will not be able to take deep breath from the mouth. In that case, we give him a face mask. So how does this face mask occur? See, in this patient, this is a spacer, inhaler, and there is a face mask. So you put this face mask and the patient can take normal breathing. You don't have to take a deep breath from the mouth. Okay. So during an acute attack, for all patients using inhaled steroids. So sometimes when the patient is in acute attack, he's not able to coordinate with the inhaler steroids. So in that case, spacer can be given to all age of the patients. So anyone who is not able to coordinate, you can give. There is no age bar in using a spacer. Okay. So basically, we generally below 4 years, we give MDI, spacer, and face mask. 4 to 12 years, if the patient is able to take with spacer, okay, MDI and spacer. And below after 12 years, generally they can take the MDI directly because they get that coordination. Okay, so this is small child taking with the mask, now directly taking with the spacer, and this is someone taking directly from the MDI. Okay. So other dry powder devices are also there. So rotahaler, disc haler, spin haler, turbo haler, and accuhalers. So there are different kinds of things. This is something you must have seen in medicine department. This is a rotahaler. It's a small plastic kind of box, and you put a small capsule with a powdered drug into it. With rotation, you rotate, and this capsule breaks, and all the powder comes into this box. And generally, you have to take a deep breath from this mouthpiece. Okay. So this is something, again, a breath activated device. You have to take a very deep breath so that this powder is inhaled in the form of aerosol, or you can inhale it. Okay, so it requires a lot of breath power. So generally children, we don't use it a lot because of this, the child is only taking, but the child is not actually getting the medicine. Then it becomes difficult for you to decide whether the drug is acting or whether the disease is very bad. Okay, so many a times we don't use it much. Why actually it is used is it is less costlier than the MDIs. Okay, MDIs are a little bit costly. This rotahalers are less costly. So that's why if you have a economic problem, then only we advise. But a lot of times We don't advise rotailers. These has been used in adult populations. Okay. So another's are spin inhalers. Okay. These are disc inhalers. So these things are there in the market, but we mainly in children use MDIs. Okay. So another thing to give is inhalation is a nebulizer. It's a drug delivery device. It administer medication in form of mist inhaled into the lungs, and it can use oxygen. Okay, for aerosol production. Aerosol is a mixture of gas and liquid particles, and particles less than 5 microgram diameter are produced in nebulizer. Okay, so that we will do in our clinical class also. We will study these nebulizers and MDIs again. So basically, there is a small nozzle in which we put the liquid, and if we put oxygen or even in this machine, what happens? This liquid is changed into aerosol in this small nozzle area. Okay, so it's also a form of giving inhalation medicine. Then our third point was regularly assessing and monitoring the patient. So after starting the treatment, we should be able to assess the patient every 4 weeks to 12 weeks. Okay. So we see the patient earliest of 1 month. If the child is doing very well, you can call him after 3 months. Okay. So during that, we do a detailed history, and sometimes we may record a peak expiratory flow rate. Okay. We assess for how is the patient being controlled or partially controlled or uncontrolled. Okay, so we assess the patient and see if the symptoms are controlled, partially controlled, or uncontrolled. So we decide that on the basis of daytime symptoms, limitation of the activity, night symptoms, need for any rescue drug. Rescue drug means salbutamol nebulizations. Okay, or we can do lung function test and we check whether there are exacerbations or not. So if we have controlled symptoms, if we have day symptoms less than twice a week, limitation of activity is none, night symptoms are none, then less than twice a week he needs a rescue drug because he has some day symptoms. Okay, and pulmonary function tests are normal and no exacerbations. Partially controlled if he has more day symptoms, activity is not affected, and night symptoms are not affected. Okay, but if he has day symptoms more than 3, but if more than 3 features of partly controlled asthma in any week, like if he has more than 2 symptoms a week, okay, or if he has lung function changes, or he has exacerbations, or he has night symptoms, in that case, it means it is an uncontrolled. Okay, only the day symptoms will decide the controlled and partially controlled. But if he has night symptoms or any activity limitation, or if he needs changes in the lung function is there, you have to say it's an uncontrolled. Okay. So if the disease is partially controlled or uncontrolled, we have to see for the cause, why it is uncontrolled. If the patient is having poor compliance with the drug, he's not taking the drug properly. He is taking the drug, but he is not inhaling that properly. So you have to ask the patient to do the process of inhalation in front of you in the OPT. Okay. Or if while doing that, you can see if the patient is doing it wrongly. Or if see if his canister is empty, his MDI is already empty, he is using the empty canister. Or your dose is inappropriate. The patient has gained the weight and your dose is not appropriate for his weight. You have to check that. Or there is some infection. He is getting viral infections repeatedly. Or he's being exposed to allergens. Plus, are you under assessment of his illness? Maybe in the last time we have assessed the illness less. He may be in the moderate persistent. We have labeled it as a mild persistent, something like that. So if we are done like that, we can increase our treatment. It's not a problem. Okay. But why is it is not controlled? We have to see it by our thorough revision of all these things. Okay. If not, cause is not found, we have to step up. We have to give higher treatment. If control is sustained for 3 to 6 months, we can step down. So whenever the symptoms are controlled, you call him 1 month, the symptoms are controlled. Then you call him after 2 months. That is total 3 months. So you keep the patient on same treatment for 3 months. After 3 months, if you see the patient is controlled, you can step down the treatment. Like if you are giving some inhaled steroid with Montelukast, you can stop Montelukast and you keep the patient on inhaled steroid. Or if you are giving inhaled steroid only, you can reduce the dose. Okay, so step down. Patient education. So Description of pathogenesis in a plain language. So we should plain language, we should tell the parents, basically parents education is more important in case of children. We should tell them that it's a bronchial asthma, it's something which is recurrent. You will not be able to remove it from the root. Okay, it's something which is going to be repeated if we do not take some precautionary measures, which can be a removing the allergens, keeping the child away from some allergen triggers, okay, or taking the drugs properly. Okay, so we have to tell them a lot of times in this point that your child needs this treatment, you have to keep it like this, you have to do like that, you have to, a lot of times you need to educate the parents. Emphasize that child can live an active and normal life. You have to tell them that he is not sick. If you are giving him medicine, doesn't mean that he cannot participate in any sport activities, or he cannot go for some hiking or something like that. Okay, so you should emphasize that the child should live a normal life with his inhaled steroids or with his medications. Okay, we have to inform them about the triggers. What are the triggers so that they can avoid that? Maintain a record of day and night symptoms. We have to ask them that keep a record of night and day symptoms if he's getting, because if you don't keep a record, we may forget and we may keep the patient at high risk of exacerbations. Understand how the medications work. Okay, and we have to tell them that this medication is being worked by this, we will keep it for this month, we'll stop it after 3 months if it is improving. So when you tell them that we are going to give it for 3 months and then we are going to reduce it, then they become more confident on you, rather than you just take it for 1 month and come back. In that case, he will say that every time he is giving me at 1 month medication, he is not telling me anything about it. So how long he is going to give? And so he will stop the medication of the child by itself. Okay, so you should make them understand how your medicines is going to work. Do you have any other class now? Can anyone tell me? Do you have other class after 3? Sachin?
Oh, ma'am.
No, ma'am. No? Do you have any class after 3? 3 बजे પછી आपको class सर? हाँ?
No, ma'am, for today. No, ma'am, for today.
Okay, I'll finish कर दिन. So, yes, 5-6 वाला class माने बाकी सब slides. I'll finish it off.
It's
Okay?
okay, ma'am.
Okay. Okay. So finally, another very important topic is whenever the patient is going into acute exacerbation, how do you manage it? Okay, so acute exacerbation is whenever the patient is having an acute symptom and he's landing up into your OPD or ER. Okay, so acute exacerbation is the increase of symptoms in form of cough, wheeze, or breathlessness. So based on the severity, it can be mild exacerbation, moderate exacerbation, severe exacerbation, or life-threatening exacerbation. Okay, so how do we decide that it's a mild, moderate, or severe? Depends upon the clinical parameters, how the child is presenting into your OPD or ER. Okay, so what is the color of the child? The child is normal colored, pink, or he's pale, he's getting very distressed and getting pale. So that is severe. Sensorium, if the patient is normal sensorium or agitated or anxious. Okay, so respiratory rate, it will be increased in all the exacerbations. Whether he is able to talk in sentences, phrases, or words. Because of his difficulty in respiration, he is able to talk in sentences, phrases, or words. In basis of this chart, okay, we will decide whether the child is in mild exacerbation, moderate exacerbation, or severe exacerbation. So generally, you get a question in which we will give you the symptoms. Okay, like respiratory rate is increased, he is able to talk in words only. Okay, he's having indrawing of subcostal chest indrawings. Okay, so if you have these kind of symptoms given in your question, you have to decide from the question whether it is a mild exacerbation, moderate exacerbation, or severe exacerbation. Okay, that's why that's why you have to learn this chart, and we have to label the patient now on which exacerbation is he. The life-threatening exacerbations are very bad. Okay, so you should know it. So reduce level of consciousness. So the patient is confused and drowsy. It means he is having life-threatening. See, in this chart, we didn't have life-threatening one, mild, moderate, and severe. Okay, so out of this chart, if the patient is having confused and drowsy, he is cyanosed and his chest is silent, or he has no respiratory effort, fatigue or exhaustion has already occurred. That's why he's not able to talk. So in these three things are there, it means he's in a life-threatening bronchial asthma attack. Okay, so that's why you should try to diagnose it. So in mild acute asthma, we should give first is we give nebulization by of salbutamol. If no improvement, if improvement is with only with salbutamol nebulization, if there is improvement, you can discharge the patient on salbutamol nebulization or MDI every 6 to 8 hourly, and you can follow up in the OPD. If he is already on the steroids and he is coming to you in mild acute exacerbation, you have to double the dose of the steroid in this case of mild exacerbation, okay? Or you can add a small course of short oral steroid, okay? But if there is no improvement after the nebulization with the salbutamol, we have to treat it as a severe form and we have to go further, okay? So after salbutamol with the nebulization, you may have to give some oxygen, okay? And the child may need admission. Along with that, we will have to do salbutamol nebulization frequently, every 2 and 20 minutes in first hour, and then after you can give every 4 hourly if not improved. Along with that, we will add some oral steroid, okay? Oral prednisolone at the dose of 1 to 2 mg per kg per day, okay? If you see that there is no improvement, the patient may have to land up into ICU care. We have to give some IV hydrocortisone. Okay, so again a steroid in the IV. In the milder form, you can give oral steroid, but in the severe form, you may have to give IV steroids. It can be hydrocortisone or methylprednisolone. Along with that, ipratropium bromide inhalation can be given every 8 hourly or 6 hourly. Then terbutaline or adrenaline can be given subcutaneously. Okay, so if still not improving, adrenaline can be given subcutaneously. If still not improving, you can give aminophylline infusion. Still you see that the child is not having distress decreased or wheezing decreased, you have to give him magnesium sulfate 25 mg per kg IV over 30 minutes. If magnesium sulfate is also not working, then only you may have to think that now the patient needs mechanical ventilation because his respiration is going so badly. He's going into metabolic acidosis and he's going into fatigue. So he may not be able to keep his respiration for a longer time. So in that case, you may decide that you have to do the mechanical ventilation. But in case of bronchial asthma, we try our best not to intubate. Okay, we try our best never to intubate. We try our best to give him only medication and avoid his mechanical ventilation, because you see during mechanical ventilation what happens, you have to put the tube into a place known as our upper airway, isn't it? We put the tube up to the carina. Now what happens? Already there is some allergy. Allergy is is making the spasm of the smooth muscles and making our airway very narrow. What happens when you put a tube in the that kind of very allergic airway? This tube is again going to work as a foreign body. Okay, and when you put the tube, it's going to keep the upper airway up to the carina. You are going to keep it patent. But when you put the tube, all the bronchioles, they go into severe spasm. But actually your aeration is not up to carina. Okay, you have to do the main aeration is occurring at the alveoli. If the part of the bronchioles from carina to the alveoli, if they are all spasm, they go into spasm and they don't open because of this foreign body, then there is no fun of doing a mechanical ventilation. You see, so the patient may sometimes go into sudden spasm and die within minutes of your mechanical ventilation because of no air reaching to the alveoli. So no ventilation actually going on. Okay, that's why in case of bronchial asthma, we avoid mechanical ventilation to our best. We try to give medications as far possible. But even in rare cases, in very rare cases, if you have nothing in your hand and the patient is already going to die, in that kind of case, you may require mechanical ventilation. Okay, so with this, our class ends up. Okay, I already told you that it's a very long class. So thank you for patient listening. Okay, if you have any questions, you can ask me. Okay. Otherwise, we can leave. Okay.
Ma'am, hypersecretion of mucus भइरहेको छ भने त्यसमा dry cough किन भयो ma'am?
Okay. About secretions, there is secretions, isn't it? Secretions is there, but that secretion is not so much. त्यस्तो mucoid भए पनि त्यो wet वाला हुँदैन यसमा, because so much secretion is not there that you can cough out that. Okay, that is little bit causing a little bit of surrounding obstruction only. The dry cough nahi huncha यसमा ल. Your question is very good. Okay, secretions is, lot of secretions are there, but they are not as in pneumonia. Like in pneumonia, what happens? The parenchyma is going into 4 phases, isn't it? Red hepatization and all those. And in the end, the tissue is going to be formed in the form of a pus-like thing, and that comes out as a cough. Okay, that's a wet cough. But here you just have little bit of secretions that doesn't come out. That's why we have dry cough. Okay.
First, ma'am.
Anything else? Thank you, Dipendra.